Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Charles Hawley, NAUTO's Director of Projects.
Thank you, Mara, and thank you everyone for joining this session, leveraging APCDs for cost insight, a topic that is near and dear to my heart. I also just want to take just a brief moment to recognize this session's sponsor, the Peterson Center on Healthcare. And I will go ahead and introduce Meredith Roberts with Comagine Health, one of our favorite colleagues. She'll be moderating today's session.
Thanks, Charles. And I want to welcome everyone to our session entitled Leveraging APCDs for Cost Insight. This is a topic near and dear to my heart as well, Charles, so I'm glad we're doing this together. I also want to thank our sponsor, Peterson Center on Healthcare, and a special thanks to Norm, Charles, and the Planning Committee for what's been a really outstanding conference so far. My name is Meredith Roberts. I'm the Executive Director of Governance and Community Engagement at Comagine Health. I'm really excited to be with you today. We have three great presentations today by three organizations that Comagine Health has had the pleasure of working with over the years. First, we'll hear from the Oregon Health Authority. This is Bert, I'm sorry. Oregon Health Authority about relative price comparisons among hospital procedures. Then we'll hear from the Healthcare Cost Institute about understanding price changes and variation. And finally, the Washington Health Alliance will be sharing what they've learned about driving purchaser value through APCD insight. So first up, I'd like to introduce Stephen Ranzoni, who is a Senior Policy Advisor with Oregon Health Authority, and Ben Chan, who's a Research Analyst with the Oregon Health Authority. They're going to share some findings about Oregon's hospital prices, which I am particularly interested in as an Oregonian. Take it away, Stephen and Ben.
Hello, everyone. My name is Stephen Ranzoni, and I'm a Hospital Policy Advisor with the Oregon Health Authority. And with me today is...
Hi, I'm Benjamin Chan, a research analyst.
And today we're going to talk to you about how OHA uses our all-payer, all-claims database to report on hospital prices for procedures. And so Oregon has a long history of transparent hospital reporting. We have publicly available databases on hospital financials and hospital community benefit activities, and we maintain public Tableau dashboards for the public to access and explore the data. Our hospital price reporting is no different, and like those other projects, it began with legislative action. And so in 2015, Senate Bill 900 passed in Oregon, creating the Oregon Hospital Payment Report. This bill created the framework for how we report because it set the initial boundaries of reporting. Statute requires OHA to report based on procedures and the frequency of procedures. OHA reports the most common inpatient, outpatient procedures. We must use the median paid amount, and we must display the data in an easy to access consumer-friendly way. And so this slide gives a brief overview of our method for extracting median prices. We start by limiting the universe of claims to just hospital claims. We do not report on freestanding ambulatory surgery centers or any other non-hospital clinic. We group procedure codes to make them more understandable to the general public. We roll up claim lines associated with the procedures to produce a price for the service, so it's not just the reporting for specific CPT codes. And then we clean up the data a little bit by removing outliers before we pull out medians. And so this slide gives us some more detail because code grouping is probably the most important part of our process. We take the individual CPT or ICD codes and group them into commonly understood procedures. So for example, on this slide, we see the 10 individual CPT codes that can be used to bill for different methods of bone density scans. Together, those codes are all considered what we call bone studies. And the amounts for any of the grouped up CPT codes are included when we report on the paid amount for bone studies. Grouping decisions were made based on both the clinical characteristics of the code and then how closely the code is related to one another, as well as the billing characteristics. So in total, OHA groups up about 115 procedures from the thousands of individual codes. These common procedures are then grouped up to 6 larger procedure categories. Those are imaging and diagnostics, outpatient surgery, inpatient surgery, chemotherapy and radiation, pregnancy-related procedures, and then lastly, and most recently added, the laboratory and pathology. And so after grouping, our data is fairly straightforward. Our data treatment is fairly straightforward. And so we roll up full claims, as we mentioned before, to more closely report the paid amount that's going to be associated with the entire episode of care. And so this would mean for including associated bill services such as drugs, medical devices, or anesthesia. We cut outliers, first by removing any zero paid claims and then taking an initial distribution from each of the procedures and trimming any observations above or below 3 standard deviations from the statewide median. And then lastly, from this trimmed data set, we extract the final median paid amount as well as the interquartile range, which is, in other words, the range between the lower 25th and the upper 75th percentile. OHA uses this range to visualize the spread where paid amounts are most likely to occur for any given procedure. So this both helps inform the consumer of possible payment ranges, but also visually represents the variance in a payment. And so now I'd like to turn it over to Ben to briefly demonstrate how we display this data on Tableau.
So here's a live view of our dashboard. Up top, we have procedure groupings, as Stephen described. I'm going to navigate over to pregnancy-related procedures and select normal delivery without complicating or comorbid conditions. On the left-hand side, we see the median prices for each hospital reporting in the state of Oregon. You scroll down, you can see the median prices and the variation. And the gray bars indicate the interquartile ranges, so you can see the variation within each facility. On the left-hand side, you can see the percent change from 2018 to 2019, and they're sorted by increasing to decreasing percent changes. And we also include the reference line at our sustainable healthcare cost growth target at 3.4%, which is soon to be implemented. And I'm going to turn it back over to Stephen.
So we just showed you our basics of what we're reporting as of today. Now we'd like to show you how we are using our basic price reporting to produce new analysis and new sources of price transparency and information. OHA is developing a price reporting dashboard, a relative price reporting dashboard we hope to be releasing in the near future. At its simplest, relative price reporting compares the commercial median paid amount to a Medicare fee-for-service median paid amount. This comparison is reported as a ratio of commercial to Medicare. This methodology can also be used to establish price trends for procedure types and settings. The next level of price reporting is using procedure groups and weighted averages to establish the price trends for key procedure types and settings. And so you can see down in the lower gray out chart to the left what we're speaking of here. From there, we can roll up all these outpatient services to report the relative prices for 2 primary hospital settings. And so that would be inpatient and overall outpatient. And then lastly, we can take these procedure groups that we've established, the laboratory and pathology, the chemotherapy, the outpatient surgery, and then we can use that like an index. And using these weighted averages, we can trend the price for these settings over time and compare the price growth in these 2 settings. And so we really hope at OHA that this new information allows for another level of reporting on trends in hospitals, trends in prices, and also provides another point for overall price transparency and policy work. And so we thank you all for this presentation, and we're happy to answer questions. Our dashboards can be found at this link, or you can go to any of your Google or other browsers and type Oregon Hospital Reporting Program into your search bar. Thank you for your time.
Great presentation, guys. And as an Oregonian, I'm very interested in the variation that you were showing. So we do have one question that's pending, and I'm going to read it out loud in case people aren't on a computer. Is this a homegrown grouping of procedure codes or something commonly available?
Yes, that is a great question. It is homegrown. That was the big stand-up project that we had to do back in 2015 when we developed this reporting. And so, we built it. We built it ourselves, just reviewing the data, reviewing the clinical characteristics. We worked very closely with the then OHA medical director to validate and vet the groupings that we made. But that is the short answer is yes, we made it ourselves.
And is this is it available to other states who might want to replicate it?
Yeah, we on that website that we'll give, and Ben, someone's asking for the link, so can you throw that link in? We'll do that. Awesome. We provide the entire crosswalk map for every year that we do it. Year over year, there's sometimes a little change. We always review the data and check to see what's going on and make adjustments as necessary. But it's pretty stable over time, and so we make the full crosswalk available to everybody.
That's great. Thank you for doing that.
Yep.
A question I had was, how have hospitals reacted to this reporting program, especially as it's gotten more granular and public over time?
Honestly, they seem fairly neutral on it. I think in terms of that question, as for like direct feedback from hospitals in the early years that we did this, the first several years that they did this, we worked very closely with them. They were actually really interested to get the data, really interested to check it and validate it and make sure that it was accurate and reflect what they thought they were even charging for these given procedures. But then over time, it became a more commonplace reporting. And I think kind of that scrutiny has fallen aside.
And another question in chat is, how will your dashboards be used by the public, or how do you hope that they be used by the public?
Yeah, honestly, I think that's a really great question. The difficulty, and I think a lot of people in here can understand, is it's hard to make purchasing decisions for healthcare, and it's very hard to make purchasing decisions for hospital care in particular. And we all know that our insurance matters more almost than anything else, our benefit design and all that stuff. And so what I really do hope is that this data continues to be a point of transparency that informs the higher level policy conversations. It was imagined as a way for the consumers to try to price healthcare, but functionally it's such a difficult thing to do. And so the use of this data is the policy of it. It's the transparency of it. It's putting that data in the public sphere to go, look, like, why are these prices so all over the map for all these facilities, and keep that in the conversation.
You just mentioned policy, and I know that that's something your agency focuses on a lot. We have a very active policy board and a very active legislature. So in your experience, what are some practical policy applications of reporting this kind of relative price data?
Yeah, another great question. I really like relative price reporting using Medicare as the baseline. And the reason I like it is because Medicare bases all their prices on the cost, right? It's not, a cooked up charge master rate or anything like that, right? The extensive, all the work that goes into the prospective system for Medicare is assigning, the relative value, the amount of resources that a certain procedure takes, and then setting a price for it and adjusting that price by wages and all that stuff. And so I think when you sort of get down to it, Medicare establishes this like cost line. This is what a reimbursement is for something and what it basically costs. And then I think by using that, it really allows you to make a lot of informed decisions or have some kind of a standard to evaluate the prices that you're seeing across in groups of procedures and full settings, or even for individual procedures.
Great insight. I'm going to do one more question, and then I'm going to invite you back at the end for a group conversation. So last question I'm going to take from Susan. Do you also include quality information? And I'm going to add utilization information about the hospitals.
We do not yet, but thank you for that question, because it is an active project we have in development, but we do not have anything out yet. And so
like next NATO conference, maybe?
Yeah, next NATO, finger crossed. We'll hopefully. No, that is very much an active project for us. So
that's fantastic to hear. Well, thanks so much for a great presentation. I will see you in a few minutes when we get through the other two presentations. Thanks so much.
Thank you.
Thank you.
All right, so now I would like to introduce Phillip Gibbon. He's a research assistant at the Healthcare Cost Institute, and he's going to share some information about Florida's price variation. I'm excited to hand it over to Phillip.
Hi, my name is Phillip Gibbon, and I'm a research assistant at the Healthcare Cost Institute in Washington, D.C. Today, I'll be presenting some of our findings from the Florida All-Payer Claims Database. First, some background information on this project. In 2016, Florida established an all-payer claims database to try to increase healthcare price transparency for consumers, and HCCI was contracted to help calculate prices for nearly 300 common services or groups of services called care bundles, and to create a consumer-focused website called the Florida Health Price Finder to make those prices available for patients. Here's an example of what you can find on that website. For each care bundle, it shows prices and details about each step of the care bundle. Where applicable, the price estimates include both professional and facility fees, and shows the state, county, and facility level price estimates. Each care bundle can consist of one or more steps, and each step can consist of one or more procedure codes. Many care bundles contain just a single service, and some more complex care bundles, like inpatient surgeries, can contain up to 20 different services. The data for the findings I'll show in this presentation comes from the Florida All-Payer Claims Database, which contains data from 9 different commercial payers and 7.7 million annual members. And I'll be comparing those findings with those from the Medicare fee-for-service data that we accessed under the Qualified Entity Program, which contains claims for 2.5 million annual Medicare beneficiaries in Florida. The data first gets categorized into inpatient, outpatient, and professional service files based on revenue center, place of service, and procedure codes. And inpatient services are grouped into DRGs. We have a set of exclusion criteria that we applied to both data sources where applicable. These include out-of-network claims, claims that did not accept the Medicare rate, secondary payer claims, irregular services or unusual payments, and extreme outliers for commercial claims. For services that can be performed both in a facility or non-facility setting, we only used either the facility or non-facility claims based on the setting where it was more commonly performed. To calculate our price estimates, we first calculated the median allowed amount for each provider, and then found the median provider for each payer, and then averaged across all payers, as you can see in the example in the table below. We did the same for the 25th and 75th percentile prices at the state, county, and facility levels. In this presentation, we'll focus on prices for professional services, specifically focusing on imaging, labs, and office visits, because one, professional services are the largest share of healthcare spending among ESI patients, and also these care bundles consist mostly of just a single service, which makes it a lot more straightforward to compare to Medicare prices. First, here are some findings on the variation in commercial prices in Florida. Each bar in these graphs shows the interquartile range, or the range between the 25th and 75th percentile prices in Florida for a sample of professional services. The shade of the bars also corresponds with the percent difference between the 25th and 75th percentiles. So the darker and wider bars have much higher price variation than the narrower or lighter bars. As you can see here, imaging services tend to have a very high amount of variation, For example, brain MRI prices will vary from $700 to almost $1,700 at the 25th and 75th percentile levels. There's also a significant amount of geographic variation for commercial prices for many services in Florida. Again, with brain MRIs as an example, the median price across counties can vary by almost an order of magnitude between the least and most expensive counties. Now I'll show some of our findings comparing commercial prices to Medicare prices in Florida. This histogram shows the median commercial price as a percentage of the median Medicare price for each professional service in our sample. Each box here represents the relative commercial price compared to Medicare for a single professional service. Most commercial prices were within 50 to 150% of Medicare prices, with most commonly services being between 90 to 100% of Medicare prices. But there are also quite a few services with commercial prices many times greater than the median Medicare price. As you can see on the right side of that histogram, these were almost all imaging services, as we'll see later. Now looking at office visits specifically, most primary care visits actually had lower median prices for commercial payers than for Medicare, while specialist visits all had higher median commercial prices than Medicare, especially nutritionist visits, in which Medicare paid a much lower median price than commercial payers did. Interestingly, most lab tests were actually cheaper for commercial payers than for Medicare, with commercial prices for most tests being around 60 to 90% of the median Medicare price, with the exception of the general health panel test, which was much more expensive for commercial payers than for Medicare. Imaging services were quite the opposite, as commercial prices were often much higher than Medicare prices, with the exception of ultrasounds, which tended to have median prices much more similar to those of Medicare. But most CT scans, X-rays, or MRIs, their median prices were much higher for commercial payers than Medicare, which adds up to a large difference in spending for commercial insurers on these services compared to what they would have spent if they were benchmarked to the median Medicare price. For example, there's a $96 million difference in the spending that commercial payers spent on brain CT scans over 2 years compared to what they would have spent if each price was equal to the median Medicare price of $122. Again, we can see significant commercial price variation across counties here for a standard primary care visit. Medicare prices don't vary that much geographically because they're set administratively and only have some minor cost of living adjustments, but commercial prices could vary from around 70% of Medicare in Gilchrist County to around 150% of Medicare in Monroe County. Here's the variation in median prices for brain CT scans across counties, ranging from $460 in Columbia County to over $2,600 in Monroe County, which is over 20 times the median Medicare price in that county. So again, significant variation in commercial prices and relatively little variation in the median Medicare price. In conclusion, commercial prices for professional services are all over the place when compared to Medicare prices. They aren't all more expensive than Medicare or less expensive. It really depends on the type of service and the geographic location where that service is being provided. Therefore, government policies that seek to benchmark or cap commercial prices using Medicare prices could have very different effects on different types of providers and on different locations because of that commercial price variation. We also had some limitations in this work. For example, we only focused on professional services here, and in Medicare claims, some of those services are often bundled with others. For example, a lab test or imaging service can be bundled into a hospital stay. So we can't see prices for every instance that a service is used in our data. Thanks for listening, and I'll be happy to take any questions.
Thanks so much, Phillip. That was excellent work. And I don't think I've ever seen that kind of variation, honestly. Having worked in this space for a long time, it is astonishing. What was the most surprising thing for you, seeing all that variation within Florida?
I mean, yeah, it's definitely very surprising at first. I think, yeah, just the magnitude of the variation and just how much heterogeneity there is between different types of professional services, and yeah, I wasn't really expecting all of that at the beginning. So.
Yeah, one thing you talked a lot about was imaging services tended to stick out as an area of variation. So I'm curious about what types of factors might be causing that wide range in prices that we see for commercial payers for certain procedures, including the imaging.
Yeah, so I think there's lots of possible reasons for this, and a lot of them are above my pay grade, but lots of people have suggested market consolidation in certain areas, driving up prices. Also, just differences in insurance networks and insurance plans can lead to very different prices for certain services, and then also just things like cost of living differences in different areas. Because of large differences in provider input costs and stuff like that. And then also quality differences, of course, which is difficult to observe in claims data sometimes, but I don't think that most experts think that like quality variation explains like all the price variation, but it's definitely a potential factor. So.
I encourage people to put questions in the chat, but while we're waiting, I'm kind of reviewing one of the earlier questions about the groupings of procedure codes that was asked to Oregon. So how did Florida go about those groupings as you explain them?
I think that happened before I started on this project, so I can't say exactly. I think there was some clinical input and a lot of work going into building those care bundles. We are kind of in the process of like reevaluating how we group services into episodes of care, so that may change some in the future. But I think it was kind of a combination of like looking at the data and seeing like what services typically are purchased together, and then making sure that aligns with the clinical input.
You noted that for Medicare, especially, it's more difficult to compare inpatient and outpatient services than professional services. Can you explain why that might be?
Yeah, so one thing for our methodology was just we required a sufficient sample size for us to calculate and report a price. So many of the care bundles in our commercial analysis just didn't have high sample sizes in Medicare, especially things like childbirth care bundles. Of course, not many Medicare claims for that. And then also the differences in how Medicare pays for services, and a lot of the services that are in the inpatient and outpatient care bundles tend to be bundled into a single payment for a hospital admission or something like that. So it was more difficult to calculate a specific price for those services using our methodology. I know other researchers such as the Rand Institute, I know, and a bunch of others I'm sure have looked into benchmarking commercial hospital prices to Medicare prices, and I think they tend to find like 2 to 3 times more expensive prices for commercial payers than for Medicare for inpatient and outpatient prices.
Well, thank you so much, Phillip. This was fantastic and really nice work for you and your colleagues at HCCI. So thank you so much.
Thank you.
All right, now we're going to transition to our final presentation, and then we'll bring all the panelists back for a group discussion. So I would like to introduce Karen Johnson, who is the Director of Performance Improvement and Innovation at the Washington Health Alliance. She's going to share what WHA has learned about how purchasers can use data to drive greater value for their workforces. Karen, over to you.
Hello, I'm Karen Johnson with the Washington Health Alliance, and I'm delighted to join the conversation on how and to share with you how we're using data to really drive improvements in value and care in Washington State. So a little bit about us. The Washington Health Alliance is a purchaser-led multi-stakeholder organization. This is a representative sampling of our members, with many of our large purchasers shown at the top of the slide. We also include health systems, medical groups, health plans, and including many other related partners in the state. The work that we do is really focused on transparent reporting using our voluntary data set, which I will describe to you. We bring folks together around issues that they care about to drive action and improvement in the state. So as you all know, transparent reporting requires data, and we're very grateful to the data partners who voluntarily submit to us claims data that we've been relying on for over 14 years. Those data partners include self-funded purchasers, labor union trusts, commercial health plans, Medicaid MCOs, and Washington State Medicaid program. We do not currently have Medicare data in our data set. So we have about 4 million Washingtonians represented with Medicaid and commercial insurance. We have, as I mentioned, over 14 years of historical data that is medical, pharmacy, vision, and dental claim data, including financial data at the allowed, paid, and charged levels. So we report statewide. This map shows the portion of the county population that we represent in our data set, with the dark blue being the most significant at about 66 to 70% of the state population, and then the dark burgundy being about 25% of the state population. And again, this is the full population in the state, and we do not have Medicare data. So for many of these states, we're representing a substantial share of the commercial and Medicaid market. What we report on is what you might expect. We look at the underuse of evidence-based care. We do that using standard HEDIS measures and other homegrown measures that we've developed over the years. We look at the overuse of low-value care, relying heavily on the Milliman Med-Insight Health Waste Calculator. We focus on variation, and we look at this in addition to at the state level. We look at it at the county, medical group, and clinic level. So I'm going to talk to you about a particular project we call the Driving Value Project, which we did with support from Arnold Ventures, an arm of the Laura and John Arnold Foundation based in Houston, Texas. These are the 8 purchasers that really partnered with us in this purchaser-led multi-stakeholder project. The primary aims of the project were to use data and convening to inform and motivate purchasers to act both individually and collectively to improve the value of care for their plan participants. So how did we do that? It started with reporting and using our data to drive action. So using our data set, we reported on both low value care using the Milliman Med-Insight Health Waste Calculator, and high value care using those standard evidence-based measures, HEDIS largely, to represent both opportunities for high value and improvement and low value reduction opportunities. So each of the purchasers that you saw listed received a customized report that compared their results to the other 7 purchasers participating in the project along with them on a blinded basis. But they were pretty open with each other as we brought them together. And then we also compared that to the commercial state average. And the goal was to agree collectively on an area that we wanted to focus on together. So as we looked at the data, just some interesting sort of points here, that about 20% of individuals received at least one low value service. Over $320 million was spent on low value care by these 8 purchasers. And the average cost per low value service was about $129 per service. In the graph at the right, you'll see the low value care services per 1,000 represented. And what's interesting is that the purchasers who are represented by the burgundy line were running higher than the Washington State commercial average, represented by the light blue line. And you can imagine that they took note of that. But I would also say that the purchasers participating in this project with us, and is, I think, indicative of actually one of our challenges in the state, is have very, very rich benefits. And so what that often does is it allows folks to access sort of indiscriminately, care that might be available to them, whether that particular service is high or low value in nature for their specific needs. So when we looked at the top 10 services based on prevalence, we found them pretty congregated. And in fact, 92% of all low value care services delivered in the analysis were these top 10 listed in order here. The one that stood out significantly is one that we've been working on in other ways in the state, but the opiates for acute low back pain continued to show up as a significant measure. Somewhere around 11 or 12 on most of the list for the purchasers was also imaging for acute low back pain. Those are two of the sort of data points that led them to select low back pain as the collective improvement opportunity that they wish to take action on. And they set about to the rest of the project to focus on how do we really increase reliance on evidence-based, non-opioid, non-invasive care, reduce inappropriate opioid prescribing, and avoid unnecessary surgery, imaging, injections, and other services related to low back pain care. One of the really important insights that we found is that, the data is great in terms of pointing to the problem, but it doesn't tell you what to do about it. So as an organization, we spent a lot of our time and energy really focused on mining the evidence, and found that the evidence for the best care of low back pain is really pretty strong, pretty well agreed upon, and has been in place for a while, including the BRIE Collaborative, which is a state-based, collaborative, consensus-driven sort of evidence-based guideline development mechanism in the state, which have reported on low back pain in 2013, said, yep, we could do things differently and better. And we're really, a lot of this evidence is not well implemented. And that was sort of broadly stated in the literature as well. So we worked with the purchasers to say, let's use all the toolbox that we have as levers for change. And let's do that in sort of a value-based and aligned fashion, so that we can align patient and provider incentives, but we can also do this across organization in a way that has the potential for meaningful impact in the market. So we selected these strategies that you see here for implementation. There are patient strategies that are designed to increase the uptake of evidence-based care for low back pain. It starts with communication and education about helping individuals understand, just what the experience of low back pain is and what good care for that looks like, and to design benefits and identify other resources that encourage the use of evidence-based care. And then certainly on the provider side, we want to implement payment models and practice level tools and resources that facilitate evidence-based care and reward success. So is that a new non-surgical low back pain bundled payment model? Is it tying on to an advanced primary care payment model that's in development in the state? Or what other sort of practice level workflow and cultural supports that we might need to put in place that are aligned with the evidence? So those are the things that we are currently working on. We're recruiting, we're beyond recruiting. We have 16 organizations committed to work with us in the next phase of this work, which will be a low back pain collaborative, which we'll be happy to talk about in our Q&A. And with that, I will end my presentation and look forward to hearing questions. Thank you.
Thanks so much, Karen. I always feel like I know so much about WHA, and then I learned something new, like this wonderful initiative that you're talking about today. So while we wait for some questions to come in, I'm going to ask a selfish one first. I have been struggling with engaging purchasers in Oregon for 8 years now. It is a long-term problem. So how is your approach to really show purchasers what's in it for them to really engage in this way? That was a lot of engagement. It wasn't like a 1 meeting, 2 meeting, and you're done. This was, sustained engagement of the purchasers. What advice would you have for us who are, kind of younger on that journey?
Yeah, thank you for acknowledging I've been doing this for a while, and also that we're having maybe some success at it. I would say, first of all, I think when you talk to purchasers, what's in it for them, first and foremost, and I spent 20 years working as a benefits consultant prior to sort of launching into some health plan and multi-stakeholder work. So I've worked a lot with purchasers in my career, and their interest is most often aligned with the patients, more so than any other. I mean, I wouldn't take providers out of that equation, but I will just say they want the best care and the best experience for their patients. So I think translating the fact that folks are getting care they should not be getting, as revealed in the low value care measures that we looked at for low back pain, was compelling to them to say, we want better for our people. We're paying a lot and they deserve better. And so I think it was crosswalking the measures then specifically to what are the levers that they can activate. So how do they both use benefit design, education and communication, as well as partnerships with providers and health plans around payment models and other mechanisms that drive change on the delivery side. So I think it was connecting the dots for them between sort of the data itself and what it says and what they can actually do about it to make it better.
I really appreciate that. And I'm going to follow up actually. You know, you used the word actionable several times in your presentation. So I'm wondering if you can share with us what you learned about how to make that data turn into action as a result of that project.
Yeah, so one of the questions for one of the earlier folks in the chat is how will your dashboards be used by the public? And if we were, as an organization, simply to put data on our website, we kind of know what will happen because we've done that too over the years. You know, we put it out there and sort of like build it, and they will come and they will use it and they will find all these fascinating facts. But really, people need data guides. And I think even as healthcare is so complex, they need more than data guides. They need data translators who can link the data to evidence in practice. And I think one of the other things I would say about purchasers is they will all say 100%, we want the best evidence-based care for our plan participants. Understanding how to translate that into a benefit design or some other communication mechanism is not something that HR and benefits folks who are focused on managing workforces that are, not about healthcare, it's not in their wheelhouse. So I think it is an opportunity for either data organizations to partner with others, or for organizations like the Alliance, who is both a data and a convening organization, to really wrap their arms around that population of folks who are really wanting to make the right decisions and do the right things for their populations, but maybe not always hearing the conversations we're having. And I'll just say this with all due respect to my counterparts who I work with for many years, they're not necessarily hearing this from their benefit consultants and advisors. They're focused on other things. So there's a big vacuum of opportunity that can be filled by data organizations, partner with the consultants, partner with other community-based organizations that represent purchasers, but making the data come alive for them is not something that's going to happen just on a dashboard.
Very true. I'm going to read a question from the chat. What process do you use to keep your claim submitters dedicated to providing you with quality data? Does the data quality vary widely across payers?
I wish my colleague, Mark Pregler, our Director of Data Management and Analytics, were here to answer that question. And he's been at this for a long time. And I will say we have, and he will tell you, the data changes and things, they'll get a file and they're like, well, wait a minute, we didn't tell you to move that field from here to there, or to stop sending it, or whatever it is that has changed. And that does create complexity on the other side. I will just say, I think that the more organizations see their data being used for good and for impact, the more dedicated they are to the data submission itself. And so the fact that, again, we're sort of have the good fortune of being both the data and a convening organization. And I think think it is the leadership who is using the data for action that has to be present in those data supplier organizations and sends that message down through the chain of command with, and sorry, too bad there are chains of command, but there are. And I think that they have to send those messages through their organizations. And it's not 100% perfect or foolproof, but I think that's an important ingredient, making sure that they understand the data is being used in a way that they are really comfortable and confident in the credibility and the privacy and the security and the accuracy of everything we're doing, but also that we're doing it with common aims and common goals.
You've certainly shared some really good nuggets with us. I appreciate it greatly. I'm going to ask Charles to bring in Phillip and Stephen and Ben so we can have a group discussion. And I encourage the audience to continue putting your questions in the chat. I see one specifically for Oregon that we can start with. For the public-facing dashboards, how easily and how well do you think many potential user groups will interpret and understand the presented concepts as well as the statistics presented in the dashboard? Great question.
It is a great question. I think we developed our dashboard probably, thinking about the wide variety of audiences that we're supposed to be delivering this to, but probably most importantly is a legislative audience, more than anything else. I think in terms of like when you think about how you do like health communication, public health communication, we probably did not develop this dashboard to say an 8th grade reading level or anything like that. But I do think it's understandable by a 12th grade standard. It is only the median. It's a range that you don't really even need to intuitively understand the underlying stats under it, just really that, wow, that hospital's got a bigger bar than that hospital that's got a smaller bar. And so I think it does a really good job of getting the concept across, and that concept really that we're preaching on in price is variation. And that's really one of the biggest takeaways. And then you don't have to be overly educated to think that's a big number when you see it next to, some given procedure at a hospital. So so bottom line is probably above a common communication level, that we say is there at the middle school level. But I think it's still fairly accessible by most.
As a follow-up,
sorry,
Ben, go ahead.
Sorry. I just want to also add in that you made design decisions to insert in the tooltips in the dashboard, some kind of plain language, full sentence, complete sentences to help interpret some of the numbers in the dashboard. So when you hover over certain data points, there's like a statement there that says this number means this, and so on.
As a follow-up to that, and this can be for everybody, depending on your audience, right, you're going to share different kinds of information or different kind of data with the audience. Have you all used storytelling at all, trying to get your points across either to the purchasers or the legislators or the public?
Were you asking me that question?
And anyone can answer.
I think that illustrating and telling stories is a really, really important aspect of this. And I think that while we don't do enough of it in our own organization, it's very high on our radar, and we're working harder and harder all the time to do that, to show just an example of how someone else has used the data. And actually this project that I described to you has become a really, I think, compelling part of the story we are telling in Washington State, because that work that I described is now, I said 16 when I recorded the video, but it's now we're at like 18 or 20 significant organizations in the state wanting to work together to drive this forward. So they're kind of writing their own story, which I think is also really, really compelling as well.
Thanks, Karen. Does anyone else have anything to add there? All right, we have a question in chat for both Oregon and Florida, so maybe I can ask Phillip to go first. Can you walk through the feasibility and challenges associated with Medicare reference pricing? Does it vary based on hospital versus insurance claims data?
I'm not sure if I completely understand the question, but we only use commercial insurance claims data and Medicare claims data. I think there are like a lot of challenges with, or some challenges with, standardizing the data, with the inclusion and exclusions that we had to think about. But yeah.
Yeah, I would, just adding on, I think, feasibility wise, we've looked across all of Medicare. We've looked at Advantage and fee for service. And what we presented today was just fee for service comparisons. In terms of just like claims itself, it's essentially equivalent data. I do think, as Phillip noted, there's problems you need to consider with how comparable it actually is. Even if it's the same procedure, the Medicare population is likely older. The Medicare population likely has more comorbidities. Something to consider, and something that also probably is even more interesting or informative when you see the commercial price is so much higher, given that the Medicare population is, generally speaking, a little bit more sick. So that's, I don't know that there's anything else to add on that.
So just on the topic of relative pricing, what do you think relative pricing data tells us, if anything, about the existence or the importance of cost shifting? I know healthcare economists talk about cost shifting a lot. So have you seen anything that can inform that conversation in either the Florida or the Oregon data?
Well,
No, go ahead.
I think that can be a tough question to answer because it is, very difficult to, determine causality, when prices change. And there's, also differences in like short run cost shifting versus long run, like consolidation driven cost shifting, when, changes in or decreases in Medicare prices might hypothetically incentivize providers to consolidate, which could increase commercial prices in the long run. But yeah, I think it is difficult to just see that from descriptive research because of the causal inference challenges.
Yeah, for my part, I'll add, I think knowing that we know that cost shifting is a controversial topic. Some strongly believe it's a thing. Some strongly believe it's not a thing. I personally, for my own part, take an academic view of cost shifting, in that X has to lead to Y, right? You have to be able to point that there is a correlation between the two things to say that one is affecting the other. I think the power of doing relative price data, particularly down to granular levels, procedure levels, is that you can then see quite quantitatively that there generally is not an X equals Y here. There is generally not this procedure's price went up, so commercial should come down, or vice versa. Generally speaking, when we, the data that I review, when I see Medicare price go up, I also see a commercial price go up. And you can start running the statistical test if you want to, and you really come up with saying that one does not predict the other. Then I'll also, not to undermine everything I just said, when you zoom out to that high level that I showed you, right, the overall inpatient and overall outpatient, you clearly see the commercial is more than Medicare, right? And so it's pretty easy to step way back and go, well, look, Medicare is that much below commercial. It must be that Medicare isn't enough. So, I think it gives you information to both sides, but if you have all that data in front of you and you can start looking at it, I feel it really works to show that the driver of commercial price is not what the Medicare price is for any procedure.
Yep. Hot topic in Oregon, right?
Hot topic everywhere.
Hey, Karen, I'm wondering if I can ask you a little bit more about how your purchasers chose the low value care topic of interest, the low back imaging. Of all of the things that they could have chosen, what in the data led them to choose that?
Well,
I think a couple things, and this is another, I think example of where one data source and one data point is rarely sufficient to draw conclusions on or make decisions around. So it was many things, but I think in the data that we shared with them and we benchmarked and discussed together, it was seeing the high rate of opioid prescribing for acute low back pain, the high rate of imaging for acute low back pain, and then just hearing, while we didn't have the data per se, but hearing even from providers that we know that the rate of injections is too high among many with acute low back pain. So it was all of those data points together that sort of said, is there something here? We also looked at people weren't getting enough recommended screening. So how do we improve high value care? We looked at, a variety of different things. But I think from the other sort of data points that were compelling to purchasers are when they look at their own data, they know that low back pain is we know from their data and all data, it's very prevalent in the US. Up to 80% of us will have some experience of low back pain at some point in our lives. And so managing something that's that prevalent, that inappropriate care can both lead to harm for individuals and excess cost for individuals and organizations. I think taking all of that together is a big part of where we got the energy in the room to reach that point where they said, yes, we'd like to continue working on this. We'd like to work on implementation together, knowing that we'll be much more impactful on the care delivery setting if we are working together. I was just in another conversation that was very much purchaser led today. And it's like, if you all could you all being purchasers and plans, could just work together to sort of tell care delivery what you want and then let them do it without creating unnecessary administrative complexity and burden and all of those other things, you'll get a lot farther, a lot quicker. And so that was a big part of this for them as well.
And I'm kind of remembering too what you said about the purchasers are going to care about what the patients care about, right? And if 80% of us or whatever are getting low back pain, that's a great point about why would they were energized.
Well, and in a commercial population, low back pain is going to impact attendance, productivity, disability. It cuts across a lot of things that purchasers care about. So it became in the end kind of an easy decision, but we spent a lot of time getting there.
Yeah, great. So I'm going to ask you each one last question that's the same. So if you could go back in time and kind of reflect on one thing you would have done different in the project that you highlighted, one lesson learned, what would that be? Do you want me to pick on somebody first, or do we have a volunteer?
Obviously, these weren't scripted because we didn't get time to sort of think about this. I think I'll lead off, and I will say that it's one of the things, and I can put in the chat a white paper that we published on this. The data is rarely sufficient. And for us, it was about the importance of the evidence and connecting the data to the evidence for purchasers. That really was compelling.
Thanks, Karen. Stephen,
I'll go ahead and go. One thing I wish we had a better capacity to do, both from a legal perspective, like the ability in statute, and then just something we address is the better identification of prices for commercial carriers, like named carriers, and that level of information.
Great point.
Yeah, so I think for the Florida price transparency work, it may have been nice to target the project a little more towards providing information for policymakers and purchasers. Since the main goal of the project is really just providing health or price transparency for consumers, since that was the original purpose of the legislation in Florida. But the benefits of this sort of work are much wider than just providing information for consumers. So
thanks so much. This was such a delightful group to work with, and I really appreciate all the time you put in working on your presentation, spending time with me, and it's really, really great work. I'm looking forward to seeing how it develops over time.
Thank you.
Thanks so much.